Well, thank you, Professor Hideman, and I want to thank the organizers and this is memorable. I've been in all these meetings, Professor Hideman and the late Professor Buchner. I have wonderful memories, and I want to thank Immune Pharma for sponsoring and inviting me to this symposium. Okay, I'm going to be giving a general talk on maintenance therapy in AML, and it'll cover the current issues I think that we have there. We know that relapse remains the most important barrier to cure in AML. We have all these fine curves that Professor Hideman showed us in the last one there. Patients relapse. And the ideal would be a non-toxic, targeted, or immunotherapeutic maintenance regimen. Now, just that we are sure what we talking when we say maintenance, the operative definition would be a therapy that is given for a period of many months, a year to 3, after successful induction and consolidation. Usually, it's not profoundly myelosuppressive and is given for presumed true minimal residual disease, that is, something that cannot be detected by current molecular technologies. Now, just that we are sure what we mean and the differences, there's a chemotherapy-based, which is always myeloablative to varying degrees. There are targeted approaches, which will come, which may or may not be myeloablative, and ideally, at least, immunotherapeutic is non-myeloablative. Let's consider where we have in acute leukemia maintenance therapy. Obviously, we have it in ALL of childhood, adult ALL, APL, and AML. And I'm going to just, so we understand the purpose of maintenance therapy, and it's not obvious. You can have maintenance therapy, and this is the historic one, say in AML, where the purpose was to delay relapse. There wasn't much evidence, no difference in overall survival in old studies. In contrast, ALL and APL, the purpose was to prevent relapse, or in essence, this was a curative approach. And the question is, how does it work, and who should get it? So I'm going to focus first on ALL in childhood because that's really the model for maintenance therapy. Now, it's the first human cancer where a long period of maintenance therapy was unequivocally shown to be critical for cure of the disease. And it's the backbone of maintenance therapies, oral 6-MP and weekly methotrexate. Now, there have been no prospective randomized studies in the era of modern intensive chemotherapy. No one has done that, but there's a compelling indirect evidence that maintenance is critical for cure. There are fewer relapses with continuous versus intermittent therapies. These have all been shown in classic papers. Shorter maintenance, every single attempt to shorten the maintenance in childhood ALL has led to more relapses, so it must be effective. The pharmacokinetics of 6-MP methotrexate correlate with relapse rate, and in vitro sensitivity to 6-TG correlates relapse. Many examples, I'll just give you one, and this is the exposure to 6-MP, and you can see that the greater exposure is directly related to relapse-free survival, a classic paper in the New England Journal of Medicine. Well, now we come to the difficult part, the mechanism of action. Poorly understood, really, we do not understand it at all, the mechanism. Very rare, curative, in states of detectable MRD. As I told you, it's really the best results in eradicating true minimal disease, which is at levels below the threshold of detection. That is 10 to the minus 4 to 10 to the minus 6, depending on the methodology. The effectiveness is counterintuitive. Everything that we learned from the Goldie-Coleman hypothesis, we need to change the drugs and different doses. Here we give the same thing for 2 years. It makes no sense how it works. There have been lots of postulates, possible mechanisms that the drugs kill a few surviving leukemia cells. The famous Don Pinkel put that forward. It's a difficult postulate. Some said there's an area of stimulation of the immune system. However, we all know that 6-MP and methotrexate immune suppressants. Maybe it controls the leukemia and allows for normal apoptotic mechanisms, just keeping it on a low burner, possibly anti-angiogenesis. It's been thrown around, no data, maybe other. So this remains a puzzle. How does it work in childhood ALL? APL, that's the other disease where maintenance therapy has been shown. This was a classic prospective study that showed that in APL, patients who did not receive maintenance did worse than patients who got some form of maintenance, usually atra with or without chemotherapy. And it's clearly effective in APL in patients who are MRD negative pre-maintenance. not after induction, but after induction and classic consolidation. And there are no data available in patients who are MRD positive post-consolidation, because these patients usually go off study and get some other so-called definitive therapy. They don't go on maintenance. So now let's move on to non-APL, or really AML. That's really the subject of today. I just gave this as a background. Now, what about maintenance therapy in AML? There have been several randomized studies. Now, there's a bit of a religion in maintenance, and there are parts of the world that don't believe in maintenance. And it's widely interpreted, particularly on the other side of the Atlantic in the US, as demonstrating that there'd be no effect. However, a careful review of the data may not support such a conclusion, and I'd like to suggest to you that there may be a selective approach to interpretation of data. And I'll show you some examples, selective ones I'll show you. First, this is looking at some studies that used maintenance. Now, in order to assess it, you want to use it as the only agent, the only post-remission strategy. And this was an old study from the CALGB. Patients got induction, and right after CR, they got maintenance, cytarabine-based maintenance. Doesn't matter. There were different regimens, either until relapse or 4 to 5 years. Now, we're going back several decades here. This is an extraordinarily impressive curve, that at 3 or 4 years, you have more than 20% alive having just received maintenance therapy. That is something what surprise. It's not a controlled study versus no maintenance, but certainly gives you a hint it must be doing something. This is an ECOG study conducted over 35 years ago, 1983, and where patients, induction, went into complete remission, and then were randomized to several arms, including an observation arm. Not ethical nowadays, was ethical in those days, and was an identical study carried out in Germany at the same time. And most of you know that the trial on the lower blue curve here was closed early by the NCI because virtually every patient on the maintenance arm relapsed. But I want you to look at different. I want you to look at the yellow arm. The yellow arm there is patients who got maintenance therapy, just maintenance. And there is a tail of 15% of patients who were long-term survivors just with maintenance therapy, nothing else. And then things went further, really burying maintenance therapy in AML, and this comes in the US mainly. And I'll give you one study that's often quoted as a study that really damned maintenance. And this is a CLGB study, a classic, a prospective study. Patients got induction and consolidation, standard consolidation, and then they got maintenance for 8 months. They were then randomized to get another 3 years of maintenance versus observation. And the data showed that the added 3 years didn't help at all. Now, that study appears in textbooks and appears in many articles I can show you, demonstrating that maintenance doesn't work in AML. But I want to remind you that every single patient there got 8 months of maintenance. It just shows you that 8 months plus 3 years isn't better than 8 months alone. It does not demonstrate that it doesn't work. Here is a CLGB study, a famous one, we all know, showed that 3 grams per meter squared is better than lower doses. We all adopted. But we all, when we look at the data that's been published, and maybe this is going to be news to some here, this published in New England, we all use 4 cycles of high-dose cytarabine, knowing it's better, because that's what was published in the New England Journal of Medicine. There are no data that 4 is better than 3 or maybe even 2. However, every single patient who got a high-dose cytarabine also got maintenance therapy. That's part of the study, but that's forgotten, virtually forgotten and almost obliterated. No one gives maintenance in the US, but that was a study. So there's been a lot of selective interpretation here. And of course, this is a classic study from this country, and one of the early presentations by the late Thomas Büchner, and showing it's a core of many of the German studies here with a marked effect. The maintenance therapy here was a lot more intensive than some of the others. This is a randomized study in older patients conducted by Dr. Lovenberg using low-dose RSC. Patients got CR, went into induction, low-dose RSC versus observation, a definite improvement disease-free survivor, but not in overall survival. So, if I can summarize, maintenance therapy is clearly effective as post-remission therapy, and there's some evidence that it may, in certain circumstances, have curative potential. It's unlikely to be of benefit for younger adults in whom very intensive therapy is the mainstay of post-remission therapy. However, it has never been studied after modern-day intensive post-remission therapy, so this is an assumption. It's not that the curves look so good. Patients relapse. Maybe we need to do something. Its role in older adults who cannot withstand intensive therapy is more compelling and needs to be more completely and definitively evaluated. Well, let's move on to targeted therapies. And I'm going to quickly look at gemtuzumab ozogamicin, FTI, farnesyl transferase inhibitors, hypomethylating agents, lenalidomide, TKIs, and histone deacetylase. Now, I'm going to pick on gemtuzumab ozogamicin because of all the targeted agents, that is the one where there have been the most impressive studies, 3 large prospective studies. And I put it here, I'm not putting it under immunotherapy. It often appears it's not immune therapy, even though it's anti-33, but it's a targeted, it's a delivery system, the 33, so it doesn't belong under immunotherapy. And this was one ECOG study. Patients after consolidation, prior to autologous transplant, were randomized to receive GO or not, and had no impact. This is a SWOG study, again, prospectively, got induction, got 3 cycles of consolidation, randomization to GO versus observation, no effect. And this was a study in older patients, published in the New England original study, and then in Blood, where patients, a large number of patients randomized to observation versus gemtuzumab ozogamicin, Dr. Lovenberg's study, published in Blood, showing no effect. So this buried GO as a maintenance agent. Tipifarnib, farnesyl transferase inhibitors, RAS inhibitor, had a short lifespan, I think, investigation. This was an ECOG study of looking at patients who got into remission versus observation, maybe tweaked out a small effect. This is what the curve looks. It's marginal if it affects. It didn't seem to have a long lifespan. Hypomethylating agents, and here we have 5-azacitidine and azacitidine. There's a lot of interest in it. 5-azacitidine is an attractive concept, data mainly confined to high-risk MDS, but currently there's several ongoing studies in AML without definitive results. There's an older study by the ERTC, which is non-interpretable, and it was small, uncontrolled, phase 2 study of maintenance, 5-AZA, but 24 patients. This is of interest. This was a study performed after allogeneic transplants, giving it in a sort, patients remained in morphologic remission, but seemed to lose their graft. They had normal counts, but the chimerism, from 100% chimerism, they went down. And there's a small number of patients who had a major response. Major response means they chimerism returned to 100%, and 4 of them actually had to sustain this. So this is very small numbers, a bit embarrassing for AML. You don't normally put such small ones, but that's what we have, and certainly intriguing. And decitabine generate a lot of interest. I put this down here selectively because this is a 350 patients study that has actually in print just a few weeks ago in leukemia. And this is standard induction, consolidation, and everybody got maintenance. So this is not a randomized study. And they got 8 cycles of decitabine. But what they did was they compared it with their last best study. So the results were comparable to previous CLGB study without maintenance. So their conclusion was that post-consolidation maintenance provides virtually no impact. And it didn't matter whether it was in CBF or other patients. So really there was a negative study, a large study, although not a controlled one. In contrast, in older patients, this is a current ECOG study that is ongoing, that after older patients have received consolidation, they get randomized to receive decitabine or observation as maintenance therapy, and we're waiting for results of this. So we still have way to go. Lenalidomide, attractive. There's several ongoing studies with or without azacitidine. This is a small study that was in 5Q based on the MDS data. Interesting, but very small and inconclusive data. The TKI inhibitors of FLT3 have been of much interest. Midostaurin, sorafenib, the conflicting data, but it's of interest. But I'm going to show you just midostaurin because that was, you're all aware of the large plenary last year in ASH where patients got midostaurin or placebo throughout induction, consolidation, maintenance. The problem is that as of today, we don't know what role it has in maintenance because this was given throughout. So that's not clear. So I think we can conclude about targeted agents, and I say this cautiously, that at the present time, there are no data or no confirmatory data available to suggest that any of these potential targeted agents will become incorporated as standard of care as maintenance therapy in AML. Of course, this may change as additional data become available. So let's look at immunotherapy. We have interferon. We have checkpoint inhibitors. I don't have data to show you, but I'm going to tell you, I think this is intriguing. There are randomized studies using nivolumab or other anti-PD-1 agents, so this could be interesting here. That's out there. It's IL-2, and it's IL-2 and histamine dihydrochloride. What you heard, there are other studies of maintenance, but I've limited to these ones that have control. You've heard about vaccine studies, and you've heard about autologous dendritic cells, but these are without control groups, so I'm not going to discuss them. Interferon was something of great interest because it was the only immunotherapy that we knew outside of transplant that could cure hematologic malignancy, and that was CML. So there was a lot of interest in AML. The MRC did a very large study randomizing older patients to interferon versus observation in almost 200 patients in both arms, no difference. This study buried interferon as a maintenance agent in AML. What about IL-2 monotherapy? Well, you heard enough from Professor Hellstrand to know this is really exciting and it should work. And so we know that NK and T cells, they mediate protection against relapse, and their function determines relapse risk in AML. And IL-2 efficiently activates the NK and T cells. There were high hopes for efficacy in preventing, and almost all groups in the US was driven by the NCI, do studies by IL-2, it must work in AML. The problem is that there were 6 studies were conducted. There was no clinical benefit in any of these 6 large studies. This is just to tabulate them, doesn't matter, but believe me, these are 6 large studies which really knocked the wind out, put the sails out, because everybody was sure this is going to work. And this was one of the most elegant. This is ERTC Gemema study, almost 250 patients in both arms. This was a randomized study after autologous transplant, IL-2 versus observation, and no difference, 44 versus 42. So IL-2, disappointingly, this was a summary that 6 randomized studies assessed in several large groups and a wide range of IL-2 doses showed no statistically significant clinical benefit when using IL-2 for any efficacy parameter. And so the aggregate data indicate that IL-2 alone is insufficient to exert a meaningful response as maintenance therapy in AML, despite the attractive biology and the expectations which were. Clinically, it didn't work, and I know you heard the story. I'm going to repeat a little bit. Professor Hellstrand, something was being inhibited, and we needed something else. We're talking about the myeloid cell-induced inactivation of cytotoxic lymphocytes. You heard that myeloid cells inactivate the NK cells, and the inactivation is explained by release of oxygen, spirits, and cytotoxic lymphocytes somehow became refractory to IL-2. Now, to make IL-2 efficacious, NKs, they had to be protected against these, from these myeloid cell-induced inhibition, and then this unexpected compound was identified, which is histamine dihydrochloride, a synthetic derivative histamine, and it's been shown that this protects NK cells from myeloid cells. And you've seen these data beforehand. And I'm going to show the slide just to summarize. Professor Hellstrand showed you, if we think that IL-2 is active, it activates the anti-tumor function of NK cells. The problem is that it's protected, and there are these myeloid cells that inactivate them there, and histamine hydrochloride protects the NK cells from inactivation. As the result, leading to destruction of leukemic cells and prevention against relapse of leukemia. That's the preclinical data and the rationale from studies why someone thought of using IL-2 and histamine. So very potent, and you show the elegant experiments. You've seen that, Professor Hellstrand. So it had to be tested clinically. So there was a small phase 2 study was published, which looked like any phase 2, as a nice curve. It told us you could give it with no toxicity. We needed to do that, so went on to the phase 3 study. This is the phase 3 study, over 300 patients, a classic study. Patients got into remission. Didn't matter how they got into remission. They were then randomized into IL-2 versus observation. You think there's a lot of heterogeneity, but it turned out that this was analyzed by country. Most countries used a fairly similar post-remission therapy. It means those that used high-dose RSC, then every patient got it. Some used autologous, and I'll soon show you. Basically, this was a regimen where patients got 3-week treatment, then 3 weeks off at the beginning. Then they got 3 weeks therapy and a bit more off. They got, but the total, over a period of 18 months, they got 10 consecutive 3-week cycles. That was it. That's what they got, versus observation. Observation was ethical because that was a standard of care. We didn't have anything. And so 320 AML patients, 100 sites, 10 countries. Patients were randomized, as we said, stratified by CR status, CR1 or more, and there were self-administered subcutaneous injections. Patients gave it to themselves at home. And this looks roughly, patients were very well matched going across the age, which CR you were in, and karyotype matched across both, whether patients got high DAC in consolidation or autologous transplant, and these are the data. You saw Professor Helston showed it briefly, looking at the overall population. This was a primary endpoint of the study, a very significant reduction or improvement in leukemia-free survival. And just looking at the CR1 population, it looked even more impressive. Now, there was a question. Some people thought, okay, IL-2 and histamine may help, but if patients relapse on it, they're going to succumb very quickly. So this is just an important piece of data that histamine dihydrochloride and IL-2 does not compromise the post-relapse survival. They do the same. Now, what about toxicity? Someone asked before, yes, there was thrombocytopenia, but you had to report thrombocytopenia. This is how studies conducted, CRO, and in almost all cases, thrombocytopenia heralded relapse. So it's not really a toxicity at the doses that we gave was not significant. Now, just to also show you, this was matched for age, gender, time from CR to randomization, karyotype, favorable, intermediate, and unfavorable. Really, this was matched across, and you can see all these forest plots looking the same. And there was, at the push from the regulatory authorities, this wasn't done initially, looking at the quality of life, no difference between the two of them. They have this for 1 hour, they got a flushing, and they got a tachycardia, but it didn't affect them overall. So if I'm going to just summarize the data that we have with histamine dihydrochloride and IL-2, I think we can categorically say, based on good prospective studies, that IL-2 monotherapy is insufficient to exert significant effect in AML. I'm emphasizing the biology. It's not enough. You need something else. The demonstrated efficacy in a phase 3 study confirms a contribution of histamine dihydrochloride when given with IL-2, exactly as predicted from the preclinical translational data. Now, the absence of treatment-related mortality, rare. There's just none. It's not on the cards, and it never happened. Combined with an excellent safety profile, represents a novel approach to maintenance therapy in AML that certainly needs to be more extensively used and explored. I think I'm going to stop over here, and thank you for your attention.
Jacob, thank you very much. Are there questions or remarks? I mean, my question is, those results are so clear, why don't we use it?
You happen to ask the same question that I've been asking for many years, and I've gone round. You've heard me before, actually at this meeting many years ago. I think there may be some complex, it moved from different companies over a period of time, but I've always been impressed with the data. Certainly these are prospective phase 3 data. They're as impressive. They're the most impressive maintenance therapies that we have out there. That is a fact. That's why it got into blood. And I've always been puzzled why it's not been used more.